So my part today is to speak about the imaging in LAA occlusion and what is essential for a successful procedure. So as we learned from Yen Ho right now, so if you want to occlude this cardiac structure, the left atrial appendage, we have to keep in mind that we have to deal with an enormous anatomical variability. And as long as we are implanting endoluminal devices in this left atrial appendage, so we depend on the endoluminal morphology. So it's worth to have a look at this. And this is maybe the main message of my talk today. So an accurate assessment of the anatomical LAA characteristics is crucial in every single patient prior to a planned procedure. So what sort of imaging modalities do we have to assess our left atrial appendage? So we can use CT, MRI, intracardiac echo, especially for the guidance of the procedure, or TE. And I would like to ask the first question here. So what imaging modalities are you considering in your lab as the best solution for LAA occlusion? Fluoro only, 2D TE, intracardiac echo and fluoro in combination, or 3D TE and fluoro in combination? So please vote. Perfect. So I think a lot of people are using 3D, as you can see here, and there's a remarkable small number of persons who are using fluoroscopy only. I don't want to look at someone. All right. So let's continue with the talk. So what could be the value of CT in our closure procedures? So we could use CT to measure our orifice diameters, and it could be shown, as we see here, that the mean diameters we measured with a segmented CT are slightly larger than the measurements we get for a planar CT or with 2D TE imaging. And as we'll see later on, we get a really good correlation between segmented CT images and 3D TE images. So we can use CT also after the procedure to look for device position. Is it still in the same position? Do we have a stable position? We can look for pericardial effusion, and we have excellent imaging in assessing residual LAA flow. As we can see here, on the left-hand side, we have a plateau occluder which is implanted, and you can see when the contrast is appearing, so we have residual flow next to this device into the left atrial appendage. On the right-hand side, we can see an image where we have a Watchman occluder in place. And again, when the contrast comes into the left atrium, we can see that there's a nice filling of the distal part of the left atrial appendage. So this is residual shunting in both of the patients. So we can use CT as well, two-phase cardiac CT angiography to define thrombi, and it could be shown that we have a good correlation between TE and CT findings for thrombi. So how to continue? Okay, so this is something I will not go into detail because we have a whole live case which is using intracardiac echo imaging for the procedural guidance. I just want to mention that it's possible to get really good imaging quality in most of the patients. You can either put your ICE probe in the right atrium or in the right ventricular outflow tract, and it could be shown if you have the probe in the right atrium in 85% of the patients, you will get an adequate imaging position over there. So let's come to the last point, the TE, and I think we all agree this is a current gold standard, and most people use it in the lab for the guidance of the LAA procedure. So how can we use it before the procedure, or how should we use it? We should use TE to exclude contraindication and to look for patients with unfavorable conditions for a procedure. The next thing we have to do is to characterize the LAA osteum and the morphology, because we are dependent on that as long as we implant an endoluminal device. And a very important step, we have to do some LAA measurements because this leads us to a device selection. So let's start one back, sorry for that. This is very fast. So this is a patient with a clear contraindication to left atrial appendage occlusion. So we see a patient with mitral stenosis. If this movie would be running, we would see that we have a doming of the mitral leaflets. So we can see in this 3D office view that we have just a bottomhole opening of the mitral valve. The commissures are fused. This is a typical rheumatic mitral valve. So we have high gradients in these patients, and this is not a candidate for a left atrial appendage occlusion procedure. So what we see here is a large PFO And this indeed was an exclusion criteria in the Protector F trial. So I think it's not longer an exclusion criteria nowadays. But if you look at a septum primum like this, and you imagine that you have to do a transseptal puncture through such a mobile septum, it can be very challenging, because if you come with your needle, you can bring this like a tent very close to the left atrial wall. So this is something we should consider when we look at the patient. I think this is a clear exclusion criteria. If you found a thrombus, like we see it here in a 3D image on the right-hand side and in a 2D image on the left-hand side, if you find something like that, you should postpone your procedure until the thrombus has resolved. So these are some patients which are clearly unfavorable in my eyes, because they need anticoagulation, long-term anticoagulation therapy anyway, and you can't help the patients with implanting a device which should protect them from taking long-term anticoagulation. So on the left-hand side, we have a patient with a myocardial infarction in the apex, and a thrombus formation can be clearly seen with different imaging modalities. And on the right-hand side, we see a patient with a mechanical valve replacement. So this needs long-term anticoagulation. So to characterize, we heard about LAA anatomy, a very fantastic talk. But if you look at the LAA anatomy from an echocardiographic view, so we can divide it in 3 parts maybe. So we have the ostium, which is the entrance of the left atrial appendage to the main body of the left atrium. So we have a neck or a landing zone, which is a tubular junction to the left atrium. And this is usually the landing zone of our devices we place. And we have a distal region, the lobar region, which is the most distal part and the most variable part of the left atrial appendage. And if you look, for example, like an ACP, how would it sit according to these lines? So we would have a disc which is covering the ostium over here, and we would have the lobe, which is located in the landing zone in the neck of this left atrial appendage. So this is how we see it in a 2D TE. And if you look at the surrounding structures, this was pointed out very clearly by Yen Ho. So I learned something, Yen, because I never called this Q-tip. So I really learned something. So for me, it's a rim to the left upper pulmonary vein, which is a neighboring structure. We have the left upper pulmonary vein in a short axis view over here. We have a close relationship to the circumflex artery, and this is the anterior leaflet of the mitral valve. And if you look at these 3D images, looking in an alphas view at the ostium of the left atrial appendage, we can appreciate how close this relationship is. So we have the left upper pulmonary vein over here and our mitral valve over here, anterior mitral leaflet, posterior mitral leaflet. So we have a very close relationship, and theoretically, especially if you place a device like the ACP where we have a disc which is covering the ostium, so we may have potentially, theoretically, any alterations of our neighboring structures. And Yen Ho already pointed this out. This is very important because we are going to put round devices in an ostium, which is generally oval in shape. And this may lead, or could lead potentially to peri-device gaps if we do bad measurements. So this is something I would like to show you, because you can appreciate very nicely the dynamic nature of a left atrial appendage during the cardiac cycle. On the left-hand side, we see a patient in sinus rhythm, and you can see we have a very contractile left atrial appendage. On the right-hand side, we see a patient with long-lasting atrial fibrillation, and this is a really severely reduced contractility in this patient. And what we see with an increasing frequency of atrial fibrillation, we see progressive increase in left atrial appendage dimensions and a decrease in its eccentricity. So this is a very important point in my eyes for interventionists who are going to close left atrial appendages. So the lobes, and we already heard that in more than 50% of patients, we have 2 or more lobes. So this can be problematic when one of these lobes is originating very close to the ostium, especially if you think you implant a Watchman device. This could be a lobe you can't cover with a device. This is another situation which can be critical when you have 2 very large lobes and a large rim in between them. It's the same situation, it's a similar situation like here. You have two large lobes and a high rim in between them. And you can imagine if you want to place a device in here, you have to make sure that you have enough space in front of the bifurcation of these lobes to place a device safely here. If you have a single lobe left atrial appendage, it plays a role for the implantation in which direction the course of this lobe is going. And this is one of the major comments I want to make. So lobes exist in different planes. And that means we need imaging in multiple planes. And this is essential to visualize the entire LAA. That means if you use 2D TEE, you need to rotate your probe from 0 to 180 degrees. And in some cases, it's even necessary to make additional rotations of the probe to look for additional lobes. So then you have to make in the next step some measurements, as we can see here. You usually do it at several planes if you use 2D TEE. So it's recommended to do it at 0, around 45, around 90, and around 135 degrees. You have some landmarks you can use. That's the level of the coronaries over here, or you can use the anterior mitral leaflet as landmark, and you can draw a line to the rim of the left upper pulmonary vein. So in this case, so we have slight variations due to the different characteristics of devices when we are doing measurements. So let's look at the 45-degree example here, for example. So if you are going to measure for an ACP device, you look at the ostium and nearly perpendicular. So the device allows a little bit of rotation, nearly perpendicular. We measure the depths according to the neck here, and the landing zone of the device is approximately 10 millimeter distally to this ostal line. So if you do measurements for the Watchman device or the Coherix device, it's slightly different because you look at the level of the circumflex artery over here, and you draw a line where you assume the device to be implanted afterwards, which is 1 to 2 centimeter below the rim of the left upper pulmonary vein. And then in the axis again, so nearly perpendicular to that line, you measure the depths. What we see as a purple line over here is the total length of the left atrial appendage in a 2D TEE measurement, but this really doesn't help because you have to expect the axis of your implanted device. So if we do 2D TEE measurements, you can follow the lines over here. We do a 0-degree measurement over here. In the next step, we do a 45-degree measurement. Then we are doing a 90-degree measurement and a 135-degree measurement. And if you look at this eccentric, so it's not severely eccentric, but it's an eccentric left atrial appendage orifice. In this case, if we have done all these measurements, we would miss the largest diameter, because in this case, in my eyes, it would lay in between those measurements. And this is what we can learn from this study. So if we use 2D TEE, like on the left-hand side, we consequently underestimate the left atrial appendage ostium orifice compared to 3D TEE. And this in some circumstances could mean that we would use a larger device in a patient where we would have 3D measurements. So if you want to go for an epicardial suture ligation, so we need an additional CT for the patient, as we see here. So we have to look if the width of the left atrial appendage in CT is less than 40 millimeter. We have to define if the shape of the left atrial appendage is compatible for snare placement. We have to look if the left atrial appendage is located under a pulmonary artery, because this would be an exclusion criteria. And we can also look at the best angle for pericardial access in this patient. So during the procedure, what do we have to do during the procedure? We have to guide the transseptal puncture, we monitor the procedural steps, and finally, when the device is in place, we assess the result, and we have to look for any kind of complications. So transseptal puncture. So what we want to have is a nice coaxial entry into the left atrial appendage. I think it's worth to think about our transseptal puncture. Why? We have a stable position of the cable vein, and we have a stable position of the ostium in the course of the left atrial appendage. So the only thing we can influence is our transseptal puncture over here. And the transseptal puncture site depends on the course and the shape of the left atrial appendage, on the shape of the delivery system you selected, and on the specific device you want to be implanted. And if you include all this, there will be one line which is perfect and gives you coaxial entry into your left atrial appendage. But if you puncture too far posterior, like over here, or too far anterior, this can make your life a lot more difficult. So it's very worth to think about it. So in most cases, this is a left atrial aspect of the interatrial septum. And so usually our puncture site, and it doesn't matter which device, it's located more inferior and posterior, as we see over here. So if we go for an ACP device, the puncture site is usually a little bit more inferior than for a Watchman device. If you use a Coherix device, it's slightly posterior, slightly inferior. So some people also suggested that you can go via a PFO tunnel. And I think if you have a very short PFO tunnel, which would end over here, it's very close to that region. But if you have a very long PFO tunnel, that brings you very far superior and anterior. And this can be a very difficult situation to place your device. So X-plane imaging, where you have two planes, a short axis view and a long axis view. The short axis view gives you orientation in anterior and posterior direction. The long axis view at around 135 degrees over here gives you orientation here in cranial and caudal direction. And this can help immensely to find your transseptal puncture site. So these are some examples where we have the ostium, which is leading down in this case, on the left-hand side. So this might be a case where you don't have to puncture too deep. So this is a case where we have a very broad entrance into the left atrial appendage, and the course of the left atrial appendage over here is nearly at the same level of the mitral valve. So this might be a case where you are better, or it would be easier for you if you puncture a little bit lower. This is a very extreme case where we have the office of the anterior of the left atrial appendage very far anterior. And if you do an anterior puncture in this case, I think you have a very hard time to get your device around here into the left atrial appendage. So and these are two examples where we have an excellent, nice coaxial entry here into the left atrial appendage. So this is a procedure where you can place your device in 20 minutes. But if you look here, it's hardly to see even the course of the delivery sheath, which is very far anterior here. Transseptal puncture was very far anterior. And it took us 4 hours to implant a Coherix device here in this case. So it really depends in some cases where your puncture site is located. So for the procedural guidance, so this is an example in 3D TEE. So what steps do you have to monitor? So this is the opening of the left atrial appendage. So we see the wire going into the left atrial appendage. The delivery sheath is placed here in this image. So here we have the positioning of an ACP occluder, which is still attached to the delivery cable. And here we have the final position of a Watchman occluder on the right-hand side. Then you can do that with every device. You can do a tuck test where you do a gentle traction to the device, and you have a look if the appendage is moving in unison with your device, and that would indicate that you have a device which is in a stable position. So if you have a Watchman device in place, this should be at a position at the ostium or slightly below the ostium. That means in this case, we would have a really good position for this Watchman device. If you look on the right-hand side, this is a device, a chicken wing morphology, as we can appreciate here. So and we have a device which is placed really deeply into the left atrial appendage, and we have an uncovered lobe over here. On the right-hand side, we see a device which is placed really high, and this might be a situation, it's placed over the ostium, and this might be a situation where a device is maybe not stable over time. For a Watchman device, we also have to confirm that we have some compression on the device. This is normally 80 to 92% of the original device size. This is measured in several views, as we can appreciate here. So in this case, a 27 millimeter Watchman occluder was placed, and we come to a compression in between 8 and 12%, which is in the range of the compression we want to have for the device. So for residual flow into the left atrial appendage, you look with color Doppler, and I want to point out that this is a very important point. You have to lower your PRF because you have low flow, and you need to lower your PRF to really find residual flow around your devices. So this is a Watchman device, and this is a common finding because it's a filter system you are implanting. And at the beginning, as long as it's not an endothelialized device, you would see flow into the left atrial appendage. But this is clearly a device which is implanted very deeply, and you can easily see that there's a gap around this device. When you use an ACP, how is the configuration you want to see after the device is placed? So we want to see a concave shape of the disc. We want to see a clear separation between the disc and the lobe, and we want to see some amount of tenting on the lobe. And on the right-hand side over here, we see an example where this configuration is met. So we have a concave shape. You can clearly separate between the disc and the lobe. And we see some amount of tenting here on the lobe. On the bottom, on the right side, so we see a device. We don't see any compression on the device. We have not a concave, but a convex shape of the disc. And you can clearly see that there's no contact of this device to the cranial part, to the cranial wall of the left atrial appendage. So this is a very unsatisfactory result. To decide if you have any alteration of neighboring structures, we learned that especially the left upper pulmonary vein is a problem, and the mitral valve apparatus could be a problem. So it's easiest to use a 3D wide angle acquisition where you can appreciate the situation very fast and very easily. So then you have to assess for some complications. As we see over here, we can have pericardial effusion, and you can get device embolizations with any of your devices. So very shortly, what do we have to do after the procedure? So we have to reconfirm the position of the device. We have to recheck if there is complete LAA seal. Okay? If it's complete LAA seal, if you have residual flow, and we have to look at the septal morphology and reassess if you have any complications. So for residual flow, it's very important because complete seal is one of the most important determinants for procedural success. And here we see examples with an ACP, a Watchman device, a Coherix device in place, and with a lariat procedure, where complete closure was achieved in all cases. But if you look at these data with a Watchman occluder, it's a very common finding to have residual shunt. So if a Watchman is in place, in 32% of the patients, we'll find at least some degree of peri-device flow at 1 year. And here we have an example where we have an extreme leak. So this was a case where we had 2 deep lobes, and Watchman occluder is placed in one of the lobes, but the other lobe, as you can see here, is completely uncovered. So this is not a good situation for the patient. This is an example of an ACP occluder. Also with the ACP, we will find mild peri-device leakages at 6 months in around 16% of patients. So this might be a little bit lower with the newer studies, but we see peri-device leakages. This is an extreme example where we have a huge leak, and again, no contact to the cranial wall. And here with a Wavecrest device, a Coherix device, same situation. We have a device which has no contact to the cranial wall, and this is a huge peri-device gap. And even with a lariat suture device, we can have residual shunt. So on the left-hand side, we see this color flow, which is leaving into the left atrial appendage after a suture ligation. And in these cases, we usually found the residual leak in the middle of the left atrial appendage. And this is something we really have to recognize. What we learned from a small single-center study is that intraprocedural leaks can become larger over the time. And we also learned that new peri-device leakages can occur during follow-up, and this means after 45 days. So after a year, we have to expect at day 0, we have a residual leak rate of 28%. So the study was done with a Watchman device. But after a year, we can expect a peri-device leakage rate of 35%. And this means that our patients definitely need serial follow-ups even longer than a year. So we look at the septal morphology. At a year, like in this patient, this was a 12-month follow-up, we find a residual leak in about 7% of the patients, but it could not be shown that this is associated with any hemodynamic changes or with an elevated stroke risk for the patient. The next thing we have to do is to look for thrombi. So this is an example where we have a Watchman device with a thrombus at a 6-month follow-up. I think the data will be presented later on, so how frequent these occurrences of thrombi are. Here's an ACP device with a thrombus, so you can help yourself sometimes with the use of contrast agent if you're not sure if you have a thrombus in a patient. And even if you have a suture ligation, like with a lariat system as we can see here, these patients also can develop a thrombus if we don't have any foreign material here in these patients. And this leads to the question how this can happen. So it's not only the device which causes thrombus formation. There has to be something else which causes thrombus formation in these patients. To conclude, so what are the essentials for successful procedure? So we have to keep in mind that our LAA morphology is highly variable, and we need an accurate evaluation. And if we do that accurately, this may help us to avoid complications in our patients. So as we saw, we need different views and multiple imaging approaches, and this can help us in characterizing the very complex nature of the 3D LAA anatomy. And an optimal device sizing, which is very important, we should avoid under- and oversizing to avoid complications, and the definition of a proper landing zone for the device positioning should be aided by a multimodality imaging approach to get optimal results for the patients. To support fluoroscopy, we should need 2D TEE and real-time 3D TEE if available. And then this is something we can learn from the per-device gaps or the follow-ups in these patients over the time, that we need that we need serial follow-ups for the patients when we want to detect these kind of complications. Thank you very much for your attention.